Perfect. So evolution and revolution are both related concepts that both describe change but differ fundamentally. Evolution tends to be gradual and usually continuous, somewhat incremental in its stepwise fashion, but its effects tend to be long-lasting. Revolution, on the other hand, is more of a sudden, extreme change in the way things happen. It may last very long or not, but the time spans for revolution are usually short compared with evolution. So I'll cover some of these ideas and discoveries as well as technologies that have played a role in pituitary medicine and surgery. So the transnasal approach to the skull base and intracranial structures was first devised by the ancient Egyptian morticians who wanted to exacerbate the cranial vault during mummification. The original technique was a sphenoethmoidal approach, and the technique was abandoned for millennia only to be resuscitated in the Middle Ages. Endoscopic techniques date from the early 1800s, almost a century before Schloffer performed the first transsphenoidal surgery in 1907. Endoscopy was driven by the need to inspect hollow organs, and Philip Bozzini is credited with inventing the endoscope. Although it provided poor visualization for the surgeon and physician, it was a painful evaluation for the patient, but it did prove to be revolutionary. Max Nitzer, a German urologist, improved on the early endoscopes by magnifying and illuminating with an internal light. However, our knowledge of pituitary disease really dates from Pierre Marie's papers on acromegaly and Minkowski's findings in 1887 of a causal relationship between acromegaly and pituitary hypertrophy. Excuse me. The appreciation that the pituitary gland was essential to life was made in 1907 by Nicholas Polesco following experiments of hypophysectomy in dogs. Sir Victor Horsley of the UK is considered to be a pioneer of pituitary surgery and claimed to have performed the first pituitary operation in 1889. Horsley published his surgical experience with pituitary tumors in 10 cases, and he's credited as the first to successfully remove a pituitary tumor through the transcranial approach. David Giordano from Venice and Francesco Durante were important pioneers of endonasal surgery. Giordano proposed a transglabellar nasal approach to the pituitary based on cadaveric dissections. His approach was internationally recognized, and prominent surgeons such as Hermann Schloffer from Austria and Theodor Kocher of Switzerland, as well as Harvey Cushing, adopted his modified strategy. Durante, Giordano's contemporary, developed a transpalatine route to the gland. In parallel at the time, ENT surgeons were applying the endoscope to the nasal cavity. And in 1901, Alfred Hirschman from Berlin modified a cystoscope to inspect the maxillary spaces. In 1907, Schloffer described the transsphenoidal approach for resection of a pituitary tumor at the University of Innsbruck, and he postulated at the time that the tumor resulted in ophthalmological deficit, and therefore a reduction in tumor volume would prove relief, which in fact it did. His approach was guided by preoperative x-rays shown here. The approach took 75 minutes without serious complications. His postulate proved true as the patient had complete resolution of both his headaches and improvements in his visual fields. His success ignited interest in transsphenoidal surgery. Harvey Cushing gave his celebrated lecture to the American Medical Association on the hypophysis cerebri in 1909, where he introduced the concept of hyper and hypopituitarism. In the early 1900s, pituitary surgery advanced quickly as surgeons in Europe and the United States developed variations of transnasal routes to the sella turcica. Theodor Kocher of Bern in Switzerland proposed a transsphenoidal approach by submucosal dissection of the nasal septum. Kocher's strategy addressed two major shortcomings of transsphenoidal surgery at the time. Firstly, the submucosal dissection of the septum reduced the risk of infection, whilst at the same time expanding visualization within the sella and had a better cosmetic outcome. In that same year, the ENT surgeon Oskar Hirsch of Vienna proposed an endonasal approach to the sella. In Chicago at the same time, in 1909, Halstead of Northwestern reported the first successful resection of a craniovaryngioma via an infranasal transsphenoidal approach as proposed by his colleague Alan Knabel. In 1910, Halstead also described the sublabial approach to the sphenoid. Halstead's technique preserved the septum and did not require a facial incision, which of course resulted in a better cosmetic outcome. Also in 1910, Hirsch performed the first direct transethmoidal operation without reflection of the nose. The operation was performed in 5 stages over 5 weeks. Hirsch then evolved the first endonasal transeptal transsphenoidal procedure on June 4th, 1910. He also is credited with introducing the nasal speculum for the procedure. Coincidentally, on that same day, June 4th, 1910, Harvey Cushing of Boston also performed the first procedure combining the sublabial incision with submucosal resection of the septum. Hirsch and Cushing corresponded, and in 1911, Hirsch demonstrated his endonasal approach to Cushing. In 1938, Hirsch was forced to leave Vienna due to the political situation brewing in Europe at the time, and he relocated his practice to Boston. Between 1910 and 1925, Cushing treated 231 pituitary tumors by the sublabial route and was able to achieve a mortality of 5.6 in an era before antibiotics and hormone replacement therapy. Hirsch and Cushing made transsphenoidal surgery the preferred approach for pituitary tumors. In addition to his classical accounts of acromegaly, Cushing also published his findings of the polyglandular syndrome that would become known by his name, Cushing's disease. At the same time, reports of obstetric infarction by Simmons in 1914 and Sheehan in 1939 further illuminated the role of the pituitary and the clinical concept of hypopituitarism. Norman Dott was Cushing's Rockefeller Fellow at the Brigham from November 1923 to June 1924. Dott co-authored Cushing's experience and continued using the transsphenoidal route upon his return to Edinburgh. Furthermore, Dott designed a lighted nasal speculum that now addressed the problem of poor illumination in the deep surgical field. Around 1925, Cushing's faith in the transsphenoidal approach began to falter. And by 1927, he began using the transfrontal approach for pituitary tumors. And by 1929, he had completely abandoned the transnasal approach in favor of the transfrontal approach. Because of Cushing's outsized influence in neurosurgery, transsphenoidal surgery fell out of favor for nearly 35 years, and the fate of transsphenoidal surgery entered a dark era. A review of patients' records from Cushing's series reveals that the reason for his abandonment of the transsphenoidal route was primarily related to the limitations of this approach in providing effective resection of very large pituitary tumors. The symptomatic tumor recurrence rate after the procedure was substantial. Furthermore, given the preoperative uncertainty about the suprasellar extent of the pituitary tumor prior to modern imaging, the transfrontal route was able to assure Cushing that he had an adequate decompression of the optic chiasm. By 1927, Cushing's mastery of intracranial surgery was accompanied by the use of electrosurgical methods that enabled him to remove sellar lesions through the transfrontal route safely with timely and effective restoration of visual loss. Meanwhile, Hirsch continued to defend the transsphenoidal approach and continued to perform his endonasal procedures until he passed in 1965, as did Norman Dott in Edinburgh. Transsphenoidal surgery remained relatively dormant, awaiting the efforts and enthusiasm of Norman Dott, who bridged the gap between Cushing and Gerard Guillot, the surgeon who then revitalized transsphenoidal adenomectomy for the future generations of pituitary surgeons. Despite the lull in surgical advances, the next revolution in pituitary disease was medical, largely from the brilliant work of Herbert Evans and his colleagues, who isolated a number of pituitary hormones at the University of California at Berkeley. Most notable were the isolation of luteinizing hormone in 1940, ACTH in 1943, growth hormone in 1945, and FSH in 1949. The measurement of endocrine function was further revolutionized by the introduction of the technique of radioimmunoassay in the 60s. The revolution continued with Professor G.W. Harris, who literally created the new field of neuroendocrinology. Harris proved that substances in the portal vessels regulate pituitary hormone function, and also demonstrated that sectioning of the pituitary portal vessels and stalk caused only temporary loss of pituitary function unless regeneration was prevented. Hypothalamic hormonal research took off following the isolation of TRH in 1966, the isolation of GnRH in 1971, and then somatostatin in 1973, and then GHRH in 1982. Perhaps as a result of the medical advances, or maybe in spite of them, the surgeons arose from their slumber, and the renaissance of the transsphenoidal approach appeared due to several key figures: Norman Dott, Gerard Guillot, and Jules Hardy. Concurrently, the development of the rod lens magnifying system and advances in fiber optics were transforming endoscopy. In 1956, French neurosurgeon Guillot visited Dott in Edinburgh, and by that time, Norman Dott had performed 120 procedures with zero mortality in his final 80 cases. Dott convinced Guillot of the efficacy and safety of the procedure, and Guillot purchased his instruments from Norman Dott and then went back to implement the transsphenoidal approach in Paris. In addition, he introduced intraoperative fluoroscopy, allowing for real-time visual confirmation of the depth and position of the surgical instruments. With Guillot's over 1,000 cases, showed convincingly that the transsphenoidal approach for pituitary tumors was superior than the transcranial approach. Guillot also demonstrated lower morbidity and improved visual outcome. Furthermore, he used the transsphenoidal approach for other tumors, such as, excuse me, please, such as craniopharyngiomas and chordomas. In 1961, Guillot was the first to report the use of an endoscope for resection of sellar and suprasellar lesions via the sublabial transsphenoidal approach. Unfortunately, Guillot was still using endoscopes based on Nitz's system, and therefore abandoned endoscopic pituitary surgery due to inadequate visualization. But he continued to use it occasionally following resection to examine for residual. Hardy studied under Guillot and returned to Montreal in 1962, where he introduced the surgical microscope in 1965. This was a great technological revolution in transsphenoidal surgery. The indications for transsphenoidal surgery expanded further to include functional adenomas, but visualization was still limited to a straight and narrow view of the sellar. To address this issue, neurosurgeons would use angled mirrors to view outside the line of sight. The superior illumination and binocular magnification enabled Hardy to perform the selective adenomectomy of pituitary microadenomas, and Hardy coined the term microadenoma in 1968. The next major breakthrough was evolving in tandem with the new development of a new lens system. In 1960, Hopkins patented a system which improved light transmission and image quality within a smaller diameter. And this also provided a wider field of view. And together with Karl Storz, a businessman in Germany, they developed and licensed the fiber optic external cold light transmission system. And in 1965, they began producing the Storz-Hopkins endoscopes. Endoscopy made many other improvements, including the CCD camera, and clinicians were then able to document their operative findings using the endoscope. Imaging brought the next revolution, with first CT and then MRI providing surgeons with a degree of diagnostic insight as never before. Operative planning and the execution of surgery improved, as did the patient outcomes. The application of molecular biology to neuroendocrinology became the next step in the evolution, as the structure of the genes encoding for various hormones were elucidated in the early 1980s. Pathological diagnosis also evolved, with immunohistochemistry, electron microscopy also providing further insights into the cellular biology of pituitary adenomas. Diagnostic testing also evolved further, with dynamic assays and, of course, the inferior petrosal sinus procedure. The development of molecular techniques illuminated the pathogenesis of pituitary adenomas, proving first that pituitary adenomas were monoclonal in origin in 1990, and then that genetic mutations were responsible for the selective expression of single cell clones. For example, the discovery of the mutation in the G-alpha S protein subunit in growth hormone tumors responsible for acromegaly due to the constitutive activity of cyclic AMP, increased growth hormone production, and then more recently, the USP8 mutation in Cushing's disease, showing that the mutation in the binding domain of USP8 leads to USP8 cleavage, excessive ubiquination, deubiquination, increased cycling of EGFR to the surface, sustaining EGFR activity, resulting in enhanced transcription of ACTH, production of cortisol, and cellular proliferation. The molecular biological revolution has brought with it a medical dividend, as first, the dopamine agonist bromocriptine, followed by cabergoline for hyperprolactinemia and prolactinomas. Secondly, octreotide and other somatostatin analogs for GH hypersecretion and acromegaly. Soon followed also by octreotide and pegvisomant, the growth hormone receptor blocker for GH hypersecretion. Excuse me. These have modified our surgical indications, have raised the bar for surgical outcomes and interventions, and have also expanded the therapeutic repertoire for our patients and physicians. The application of the endoscope to diseases of the paranasal sinuses was the catalyst for reintroducing the endoscopic endonasal approach. In 1978, Wolfgang Draff reported his clinical experience on the therapeutic endoscopy of the paranasal sinuses, and along with other ENT surgeons, including Heinz Schamberger and the American Dave Kennedy of Philadelphia, together pioneered the functional endoscopic sinus surgery procedures for the maxillary, sphenoid, and frontal sinuses, and coined the term functional endoscopic sinus surgery. This reintroduction of the endoscope underlined the limits of the microscope and proposed the new case for endoscopy, first bringing light close to the deep field and being allowing to observe and see asymmetric tumors and lateral extensions. Excuse me. Almost concurrently, in the 1970s, two separate groups used the endoscope as an adjunct to the microscope for tumors with extracellular extension. In 1977, Apazzo and his colleagues from USC reported that the combination of techniques allowed the visualization of anatomical landmarks and provided for better tumor resection. Busch and Haus in Germany also published a similar technique in 1978. The joint efforts of both the neurological and ENT surgeons led to the emergence of what was then known as the, quote, pure endoscopic transsphenoidal technique in the early 1990s, where the endoscope was used as the only visualization tool. Roger Jankowski in France reported the first use of this, quote, pure endoscopic sublabial technique for cellular lesions in 1992. And in 1995, Sethi and Pillay at the Singapore General Hospital described their pure endoscopic endonasal transsphenoidal approach for pituitary adenomas. A couple of years later, Joe and Carrao in Pittsburgh used the endonasal uninostril technique without a nasal speculum. The techniques and indications for endoscopic transsphenoidal surgery have continued to expand with the introduction of other technical adjuncts such as neuronavigation, microvascular Doppler, and miscellaneous other instruments. In 2003, Giorgio Frank and Ernesto Pasquini developed the transethmoidal, transpterygoid, transsphenoidal endoscopic approach for cavernous sinus lesions and tumors lateral to the carotid artery. And then the transtuberculum, transplanum approaches for anterior skull-based lesions, such as tuberculum cellar meningiomas, olfactory groove meningiomas, and craniopharyngiomas deep inside the brain. The concepts and applications of endoscopic transsphenoidal surgery have continued to expand. This is a short video of an expanded transphenoidal, transtuberculum, transplanum operation for resection of a craniopharyngioma. This is the tumor underneath the chiasm extending to the third ventricle, as you saw in the MRI. The dissection is proceeding to elevate the chiasm and dissect the tumor away from the undersurface of the third ventricle. Gentle debulking of the tumor from below to allow the suprasellar and the supraventricular portions to descend, and then freeing up that tumor. This would be difficult to do without an endoscopic approach that is shown here. Then the tumor being delivered, and even large tumors that extend deep inside that might be candidates for transcallosal approaches can be removed successfully with expanded endoscopic transnasal approaches. With the new endoscopic techniques have arisen a new set of challenges and limitations. Notably, the loss of depth perception with standard endoscopes, the collision of the endoscope with surgical instruments, which can result in restricted mobility and bimanual techniques. These limitations are being addressed with the development of newer endoscopes, such as 3D endoscopes, shown here, malleable endoscopes, and further instrumentation refinements to produce better and more effective instruments for surgery. And then finally, I think it's important to understand that life doesn't get better by chance, it gets better by change. So evolution and revolution have been outstanding drivers of our successes in pituitary medicine and surgery over millennia, dating all the way back to the Egyptians and the morticians exacerbating the skull, to today's sophisticated endoscopic expanded transnasal approaches that have increased the ability of surgeons to do the work we do. So thank you very much. And I, again, want to pay my respects, my very deep respects, and to both Rudy Falbush and Ed Laws for another outstanding milestone in their wonderful careers, and thank them for all the things that they've taught us over the years and their great friendship over the years to me personally. And I yield the floor, Dr. Kanan. Thank you so much.
Thank you, Nelson, for this wonderful presentation, combining all the aspects of the evolution together and give an inspiration for the future development. We'll can give 1 or 2 minutes for comments or some questions.
Yes.
Rudy.
May I ask you, because you have contributed also a lot in molecular biology. How far would you recommend a young neurosurgeon who wants to go into pituitary surgery to deal also with that? Because I think some of us had a molecular biological lab in neurosurgery. Is it today even sensible, because it's so complex, that a neurosurgeon will go on dealing with this personally in a lab?
Yes, I think there's continues to be a role for us to collaborate and interact with our colleagues in molecular biology, molecular neuropathology, and of course, medical neuro-oncology, because I think the advances can only come if we are involved and we are part of it. I think we're a very integral part of patient care. We obviously operate on these tumors, and we retrieve these tumors. And as you know, my dear friend Michael, your protege, was at the helm of the investigations in the USP8 mutation story with Cushing's, and the neurosurgeons also in Shanghai were part of that whole investigation. So I think it's very important that we keep our fingers in the pie, and we collaborate, even if we don't do the experiments ourselves, but we are part of that evolution and revolution story. And we have a lot of bright minds in neurosurgery, a lot of smart people that can help advance the field in collaboration with the molecular biologists and neuroendocrinologists.
Thank you.
Ahmed, may I have a question?
Yes, yeah, go ahead, please.
Thank you, Ahmed. Thank you, Nelson, for this really wonderful overview of evolution and the revolution of the pituitary adenoma. I would say pituitary disease, because you are speaking not only about surgery but about also medicines and many. So my question: how about simulation in your talk? There is a place, there is revolution simulation for a learning curve or not, especially in a transnasal endonasal operation, endonasal endoscopic approach.
Yes, Nadia, thank you so much. I think there's a great role for simulation, for sure. Technology today has brought in things like virtual reality, 3D animation, and augmented reality into the classic teachings in the cadaver lab. And one of the shout outs I want to give is I want to mention the work of Gabi Zada. Gabi is at USC, and he has, for example, put together this wonderful simulation of carotid artery injury during pituitary and transnasal surgery. And the student, the resident, fellow, attending surgeon can operate and then have that carotid artery injury simulated over and over again. So you practice getting control of that surgical emergency, for example. And of course, you can also use simulation in other areas of the surgical procedure. But I mentioned that as one of the good examples, the classic examples of the role of simulation in transnasal pituitary surgery. Yeah.
Thank you. Thank you.
Thank you, Nelson. Well, I hope that the analogy of revolution with the political revolution does not match the same things, because revolution in politics can be catastrophic, or you might have the result delayed. And I think here we are having the result almost immediate. The revolution in the evolution of technology, we are getting the good results, and we are progressing on this one. Is there any other question or comment, please? If not, well, thank you, Nelson, for having the time to share us. I know you have a busy schedule.